good to have you with us on the 9 p.m. edition of the Urban Debate. Is the coronavirus not always getting detected by the widely used gold standard considered RT-PCR tests? Are hospitals now getting cases where a patient with even the typical symptoms of COVID is still testing negative repeatedly for COVID with the RT-PCR? 2 times, 3 times, there are instances where 2 times, 3 times the tests have been done and it shows negative. But the patient does have COVID. This is a trend which is also observed in smaller parts in the first wave, but seems to have come back in a bigger manner in the second wave. Now, for you and me, this is extremely shocking, of course. Most people tend to believe that RT-PCR test, if done at the right time and in the right manner, is the ultimate on whether or not I have COVID. And we go about living our lives accordingly. But it now seems that there is a possibility that it may not always be completely true. What are the alternatives that the experts are looking at? Doctors are now then, in cases where they see symptoms but negative RT-PCR reports, they're prescribing CT scans. More sensitive, specific and accurate scans to detect what's going on, to detect low oxygen. They're also doing several other medical procedures to effectively get into your chest and your lungs, pull out the fluid from there and then test it to see if it's been infected. And there are now cases from Bengaluru to Gujarat, Surat and Rajkot where such instances have been found. This detailed test has shown that the person is indeed infected. I still have very limited understanding and I have many questions, but this is one of the issues that we wanted to talk about, to bring to your attention and have experts break it down for us. So Dr. Sanjeev Badwar, good evening to you, Head of ENT Services at Kokilaben Dhirubhai Ambani Hospital in Mumbai, joining us this evening. Dr. Deepak Natarajan, Senior Consultant
Good evening.
for Interventional Cardiologist and a public health expert, joins us this evening. Dr. Lancelot Pinto, Consultant Pulmonologist at the Hinduja Hospital and MRC. Dr. Anup Amarnath, Chairman for the Geriatric Medicine at Manipal Hospitals, joins us this evening. And Dr. Vikas Maurya, Director and HOD Pulmonology for Fortis, joins us this evening. So thank you so much to all of you for being with us this evening. Dr. Badwar, I want to start off with you. What can you tell us,
yes,
and how much of this has been observed as a trend?
See, the current variant is a threat. It's highly infectious. It's infecting faster. And as you can see, 1 out of every 5 new case of COVID-19 is from India. So this is a threat. But the brighter side is that all of us have been addressing it for the past 1 year. So yes, we are aware of it. Measures are in place. Our strategies are changing every day. As you know, this disease teaches us something every day. So we have to evolve new strategies in testing and treating. But the best part is that over 1 year, experts around the world have formulated strategies and a standard protocol for treatment.
Okay, but have you now observed this, and your colleagues as well, that there are more instances this time around where COVID infection isn't getting detected by RT-PCR, and then what is done to further investigate?
Madam, the way it works is that this RT-PCR COVID-19 test still remains the gold standard. These tests, even prior to this, have a specificity of 70 to 80%. So this is not a foolproof test. And every medical professional knows that. When you're treating a patient, you're guided by the test you have at hand, the clinical history, history of contact, and where indicated, certain additional tests are done. But what is different in this wave is that it is suggested that the period of incubation of the virus and the viral shedding in the nasopharynx is of a shorter duration. Therefore, the virus may migrate downwards towards the lower respiratory tract. And we have newer strategies to combat that. So I would like to again re-emphasize RT-PCR remains the gold standard, and all clinicians are aware of this, and they have strategies in place to tackle RT-PCR negative cases.
It's important that we highlight this, because while you, of course, and everybody in the medical fraternity here knows, and you know, you would do your due diligence in finding out what the infection is and how to treat it, people don't. Now, if I have cold and mild fever, and I go and get myself tested, and the RT-PCR tells me negative, I'm going to assume it's just a seasonal flu. And I'm going to go about living my life accordingly. And I feel that becomes a problem, Dr. Pinto, when people don't know that this is a possibility. So what would be the advice to the viewers right now? At what point do we say, okay, no, maybe we should get ourselves tested again, or any which ways go visit a doctor?
No, I think that's a very valid point. And the bottom line is that the number one cause for a cold, a fever, upper respiratory tract symptoms right now is COVID by far. It surpasses every second cause that may come after. So if you have typical symptoms, out of 100 people who do have COVID infection or who are infected with the virus, if we did swabs on 100 of them, despite them having the virus, 70 of them would test positive, around 30 of them would test negative. So a negative swab in the context of a respiratory tract infection and fever should not be reassuring to anyone to the extent that the person gets out of isolation, the person moves on with his or her life. I think it's extremely important to get a second swab. And you know, it's probabilistic at the end of the day. So if you look at one swab having a probability of 70%, if you do a second swab, that probability increases to about 97% or so. The sensitivity dramatically improves. The other thing is you also should look at context. So this sensitivity of 70%, that it will pick up 70%, is in the context of symptomatic infection. So somebody who has symptoms. The sensitivity is likely to be lower in the presence of no symptoms if you do it too early as part of contact tracing. So if somebody else in my house has it, develops symptoms today, and I immediately go and test, maybe it will come negative at this point of time. But 2-3 days down the road, when I do have fever and I test again, that's when it's likely to be positive. So I think testing at the right time is important, and realizing that a negative test should not reassure oneself in the context of having symptoms that are the cause of which by far right now in the city is COVID-19.
So then the follow-up to that would be, and Dr. Amarnath, maybe you can come in on that. In the first round and in the initial days, we were told that you wait for a certain days after you've come in contact with somebody who may have tested positive, 4 to 5 days, then you get yourself tested, and that would be perhaps an appropriate time to see if it shows up in your results. Has that changed? Because this virus is now spreading faster, it's catching on quicker. Does that change?
No, I think to put it in context, we need to look at, I'll answer this in two parts. Part one, we have to look at COVID from 4 angles. And we've said this in the past, I'm repeating this again. Number one, RT-PCR is the gold standard. Number two, we need to look at clinical symptoms, upper respiratory tract infections, and with the new, with the second spike, gastrointestinal symptoms as well. So symptoms become the second angle through which we look at COVID. Number 3 is the lab test. There are 4 specific markers that we look at: D-dimer, ferritin, LDH, and IL-6. So those are something which we need to do when you're investigating a person for COVID. And the 4th angle is a CT scan, a high-resolution chest CT. So whenever you have suspected a person to have COVID, it is ideal to do or evaluate that person from these 4 angles. So as you rightly said in the beginning, you may have an RT-PCR negative, but you'd have the CT scan being positive. There's a specific entity called ground glass opacity. So if you see that on a CT, a suspicion of that person having COVID is high, that combined with symptoms and the inflammatory markers being elevated is an indication to treat a patient for COVID, even though that person may be RT-PCR negative. So look at COVID not from one angle of RT-PCR, but from the 4 angles of symptoms, blood test, CT scan, and the RT-PCR. Number 2,
right.
Yeah,
Go ahead.
No, the second part, which I said, is that, when you look at a first negative RT-PCR in a symptomatic patient, we always say that day 0 is when we do the first test, and then day 5 to day 7 is when we repeat the test if the first test is negative. So the guidelines haven't changed, but I think for clinicians to look at COVID from all 4 angles is very important.
Okay. So you've listed out a series of other checks that must be done, diagnostic tests that must be done. Now, so Dr. Maurya, do we have an infrastructure in place to do it at such a large scale when you have 1.8 lakh cases being registered on a daily basis? Will this lead to some kind of a pressure on the diagnostic labs and hospitals again?
Yeah, I think I agree with you. I mean, there is an increase in the number of cases, but I think the labs at the moment, what we are hearing, they're doing more number of testing. The capacity is being increased at the private level as well as at the government level as well. So this, for example, earlier the cases were low, so they were doing less number of cases, but now as the cases have increased, so you are doing, more number of testing. So I think you will be in a time then you will have more number of testing centers in every areas of the country. I mean, this is something new for everyone, and this is the rise which we are seeing at the moment is a very, very rapid rise. So obviously the things do lag behind, but they will do catch up. So that is what we feel about it.
No, but that's as far as, say, antigen tests or RT-PCR tests are concerned. Now, if we say that there are larger percentage of cases where you may need to follow it up with a CT scan or HRCT and other options, now are we ready to do that? And for how many cases will we be able to then do that kind of a follow-up?
See, again, I said, usually in milder cases, you don't need a CT scan or, these tests or bronchoalveolar lavage or something like that. Only in cases where you suspect. I think these are left to the doctors to decide in which cases, yes, if they want the CT scan to be done in these patients who are having, lung involvement, having respiratory symptoms. And usually, you can obviously, on the basis of the symptoms, also patient treatment can be started. Patient is having a cough and breathing difficulty with fever, COVID is positive, you can start the treatment. CT is done basically to know the severity of the disease. Otherwise, the clinical parameters, the oxygen levels and everything, the treatment can be started, right? The only thing is the diagnostic, which is said. The diagnostically, if we see, yes, for example, if the PCR is negative, but patient having symptoms suggestive of COVID and he's having a breathlessness, you are doing a CT. CT then show us, yes, this patient is maybe a case of COVID. So yes, CT then have a diagnostic value. So it's not that every patient need a CT. It's a clinical, it's a clinical diagnostic thing which the doctors will decide which patient need a CT and which patient does not.
Okay, Dr. Natarajan, is this something that is is being observed larger in some part of our country? Is it something that's also been observed across the world? This evolution of the virus is obviously happening differently in different places.
No, that's a very, very important thing. So, before I elaborate on what I have to say, first we must do a math. When we do the math, we find that, let's presume that we've had 1,000 deaths yesterday. In fact, the exact number is 1,026 deaths. Now we go back 10 days because deaths trail the cases by about 10 days. About 10 days ago, we had about how many cases? Almost 1 lakh cases picked up, right? Now, if you pick up 1 lakh cases, that means in reality, at least you have 10 lakh cases going around. So which gives you an infection fatality rate of just about 0.1%. So once we have that figure, we have the infection fatality rate of 0.1%, then we know that even though we have lots of cases, the fatality is not high. So straight away we know that despite the fact that there are variants, there is what is called a double mutant or a triple mutant or whatever, the mortality is not peaking, the mortality is not exaggerated despite the variants. Now we have 2 papers published just about yesterday in the Lancet. Both papers are of course on the Kent variant, that is the English variant, and they clearly tell us that maybe the infection rate has increased by about 30 to 35%, but the fatality remains the same. There is no increased lethality. Now we come to this point about PCRs being negative. Now that will always happen. In any part of the world, the RT-PCR will turn out to be negative in some cases. Now that is nothing to be alarmed about. As a cardiologist, very, very frequently we do treadmill tests in people whom we suspect are having heart disease. And we find that some have a negative treadmill. That means the treadmill test is suggesting that there is no disease. However, they actually have disease. So we have to keep the clinical picture, the clinical profile in our minds also before we come to a definite conclusion, before we interpret the treadmill test. So similarly here, if I find a patient who is having symptoms of fever, cough, right, and the PCR test turns out to be negative, it depends, as other speakers have said, it depends upon the date, because the false negatives are at the least on the 6th or 7th day of symptom onset. So even if you have a negative PCR test and you suspect the person may be having a COVID, then you launch your protocol, you begin your treatment. Now, there are different kinds of patients. The majority have mild COVID-19. For instance, just this afternoon, my neighbor contacted me and said that he has turned out to be RT-PCR positive. So that's fine. He has a mild disease. He can stay at home. He doesn't need to go into a hospital. And the other very, very important thing is that every society of radiology in the world has agreed that the CT scan is not to be used for diagnostic purposes, nor is to be used as a screening procedure in patients of COVID-19. We still have to fall back on the RT-PCR. CT scan is done if the presentation is atypical on a chest X-ray, which means that the protocol demands that if a patient gets admitted and if the patient is having moderate symptoms, or if a patient is having comorbidities like hypertension, obesity, diabetes, or if the patient is on immunosuppressives or is elderly, then that means there are risk factors. In that case, we do a chest X-ray, and if the chest X-ray has the classic findings of bilateral, opacities, bilateral GTOs, that is ground glass opacities, then that's it. We begin the treatment, we begin the therapy, which largely is oxygen and antivirals. However,
so I'm a little confused. You're saying that CT scans are not the way, are not the right diagnostic test to follow this up? Because my understanding is, and in fact, there are certain civic bodies in this city, in this country, including Vadodara, which have actually now put out a notification saying don't stop at RT-PCR and go ahead and carry out these scans. That's just confusing me.
That's a local phenomenon, but if you care to do the research, if you care to follow the American College of Radiology, then they have clear instructions that the CT scan is to be used.
So you would say that we do an RT-PCR test and we do it again if needed, and then an X-ray to follow it up?
Yes, exactly. That's how everyone. In fact, we had a radiologist in this meeting. We should have had a radiologist, an expert in radiology, to give us their comments. That is how it is being done all over the world. The only country which began with the CT scan was China. That was right in the beginning when people knew very little about this disease. Right?
Okay, fair enough. Interesting point. If I can take it across to others, Dr. Pinto, and I ask this question because I personally know at least half a dozen cases where CT scans or HRCTs have been prescribed to further do an investigation.
So I mean, my honest opinion is that CT scans are completely overused in COVID-19 in India. And if you ask me, if you look at any diagnostic test, the reason you do the test is, number one, to prove the diagnosis. Number two, to either prognosticate or say, that this person is going to do well, this person is going to do badly. And number three, at the end of the day, every test has to change the way in which you manage a patient. So in terms of diagnosis, CT scans are about 85% as sensitive as an RT-PCR. So if the RT-PCR is about 70%, the CT scan will pick up 85% of this 70%. So it's even inferior to an RT-PCR. So it's not going to add value in terms of a diagnosis. The second question is it going to change management? So can your doctor tell you that if you have a normal or a mildly affected CT scan at baseline, you will definitely not deteriorate with certainty? The answer to that is no. Will a doctor get more information? If the CT scan looks bad, is it likely that your oxygen level will be normal, or there'll be no other indicators to suggest that that you're not doing well? And the answer to that is yes. So it's very rare that you will have a CT scan that looks really bad in a person looking absolutely fine with normal oxygen levels. So you can get pretty much the same information clinically that you get from a CT scan. The bigger question, though, is what are we going to do different, right? So
Yes.
if the CT scan looks, do we have any special drugs that we reserve only for those who are severe? Versus, can we alter the trajectory in some way by the way the CT scan looks? And I really don't think the answer to that is we do anything differently based on the CT scan.
Okay.
So if you look at the guidelines, the only role for a CT scan is for a rule out. If you have, say, 2 RT-PCRs which are negative, and now you want to know, could this be a pneumonia, a bacterial pneumonia? Could this be something else going on in the lung? You would do a CT scan, because then if you look at an atypical picture, you say this does not look like COVID. But I firmly believe that CT scans are extremely overused in this country and probably have a very, very limited role in the management of COVID-19.
Dr. Natarajan, you wanted to come in?
Yes, because I agree with the good doctor. And apart from this, it is very, very important for us to realize that we cannot compromise our radiology departments. You see, in case, for instance, in my hospital, we have a brilliant CT scan. We have a, 184 slice CT scan. I cannot send every patient into that area, because just in case I infect the technician, or in case, not I, but the patient infects the doctor, the radiologist, then I've had it, because then the department goes down for at least 10 days or 14 days. So therefore, a CT scan has to be used very sparingly. It is not, it's not the run-of-mill procedure. It is not to be used, at will and just for the sake of it. It is very, very important that a case which seems to be atypical or a case which is deteriorating, that is the sort of a person who would need a CT scan.
It's also extremely expensive. So I'm hoping that we're able to find other ways to detect a COVID
if I can just add to
infection that the RT-PCR doesn't. Yes, Dr. Pinto.
So if I can add to that, what's the guarantee that radiology places aren't going to become super spreader events if you have person after person after person come out there?
Got that
How
point.
are you going to ensure such a
Correct.
high level of sanitation and sanitization if you have so many people coming there?
Correct. Fair enough. Okay. So I am going to again try and simplify this, and because at the end of the day, I'm right now thinking like any common man who has zero understanding of all the technical terms you all are using. So Dr. Amarnath, would it be fair to say that if you have any symptoms at all, or if you did come in contact with a COVID patient, even if it's not showing yet, you go to a doctor, you don't leave it to yourself to do an RT-PCR and drop it at that?
No, I think that's a very valid point. Self-medication, self-diagnosis, especially with COVID, is something which no one would advise. And if there are symptoms, yes, RT-PCR is something which is and will remain the gold standard. But I think one thing which we really need to emphasize here, because this is on the ground clinical experience. Just with an RT-PCR, there's a specific entity in COVID called happy hypoxia. So you may be comfortable, but then your oxygen levels are low. And that is where the CT scans help. And then, we had this discussion about, does CT change my clinical management? And the answer to that is an emphatic yes. If the CT shows GGOs, there is a scoring that is done on CT scans. If the scoring is high, the treatment changes. We no longer keep them on home isolation and oral tablets management, but then start off on intravenous, whether it is antivirals or steroids or anticoagulation. So the fact of the matter is RT-PCR remains the gold standard. Not to self-diagnose and self-medicate, seek the help of your doctor. And as clinicians, I think we have to be very scrupulous in when we use CT. And CT does change our clinical management. I think that's the bottom line.
Okay, now that's the first part. And the first part, Dr. Badwar, is where we spoke that if you have symptoms, you don't stop at an RT-PCR. There's a possibility you have the infection that doesn't show up and you figure out otherwise, you go to your doctor for help. The second aspect I wanted to ask all of you experts is the change in the symptoms. Are we now watching out for newer symptoms as well as the virus evolves that we didn't see earlier? I now find way too many people also complaining about, body ache and joint pain much before some of the other symptoms. Would you be able to shed light on that, Dr. Badwar?
Yes, ma'am. We are seeing some new symptoms. Like in my practice, I'm getting a lot of people with hearing complaints, with tinnitus, with what you call the pink eye, gastrointestinal symptoms, vertigo at times, dizziness at times, pain abdomen, and most important, a lot of people are coming with vascular complaints. That is discoloration of your fingers, your toes. And in my hospital, my colleague in the Department of Vascular Surgery has been saying that he's getting a lot of patients of late with complaints related to the vascular supply in the lower limbs, leading to major surgical interventions.
Wait, you're saying surgical interventions in the sense they need surgical treatment as surgery as well, apart from simply just treating the COVID infection?
Yes, ma'am. More and more what is happening of late, like in my practice, I'm seeing an increasing incidence of life-threatening fungal infections in the sinuses for those patients who have recovered from COVID. We used to do such cases once in a while, but of late, I mean, every week in my practice, 1 or 2 patients have to undergo extensive sinus procedures. And my colleagues in the vascular surgery department have also, given a history that.
Oops, we have seem to have lost that line with Dr. Badwar. We're going to try and get him back as well. But any of our other experts, Dr. Vikas Maurya, would you like to comment on this one as well? I think it's extremely important for people to know what are the new symptoms they should be watching out for and not dismissing as anything else.
See, what I would say that if you talk about majority of the patient, now presented with, having body ache, then headache, then followed by fever. Now what we are seeing is that more and more patients are having a fever for longer period of time. Earlier, fever was there for a shorter period of time in the milder cases. But now even in the milder cases, what we are seeing, the patient is having a fever for 7-8 days. And if you go on doing the other tests, it came out to be negative. Their saturation is fine. And like this, the fever is more the other symptoms, like for example, the gastrointestinal symptom, like GI symptoms, they are more nowadays, which was less earlier. So what we're seeing, the symptoms are same, but the severity of some symptoms have increased. And now the patient, for example, the lung involvement, if I talk about at this time of the way, what we're seeing that the lung involvement is coming quite earlier in the patients presenting with moderate to severe disease. Earlier, what we are saying that really in the second week onwards, they start having cough or something, fever, breathlessness. But now we are getting more patients coming in earlier part with cough and breathlessness in the first week itself. And secondly, what we are seeing at the moment is more younger patients are coming with moderate to severe disease than the last year way that we have. We have more of elderly patients, but now we have more of younger patients are also coming along with elderly patients as well. So that's something new which we are seeing in this wave, which is spreading very fast, and more number of patients are involved.
So let me ask you this question: is the higher number of cases amongst youngsters a reflection of the virus's change and evolution, or is it simply because more number of us are stepping out now to get to our workplaces or travel or whatever, attend weddings? Earlier we were all in a lockdown.
See, I think we cannot say, that the virus, could be possibility. Maybe we are having a different strain of virus. Maybe another strain of virus is spreading. The second aspect is, yes, people is having a pandemic fatigue and everybody is moving out. Nobody is following COVID appropriate behavior. And that's maybe the cause of, more younger people are being involved in this wave. And again, having more number of patients coming with moderate to severe form of the disease. So it's very difficult to say that which is important, but it maybe one or both may be important at this point of time.
Dr. Badwar, we lost the line with you earlier. If you wanted to go ahead and finish your point.
Yeah, so basically, you see, the COVID-19 attacks the vasculature and it causes an increased incidence of thrombosis, what you call it. So when it affects the peripheral limbs, there's an increased incidence of vascular episodes. And of late, we've had patients coming to our hospital with gangrene of the limbs, where the vascular surgeon has to address it by amputation. So it's not the disease alone, but what all ramifications and side effects we are still learning. In ENT practice, I'm having a greater incidence of sudden hearing loss, which we treat, of course, with the standard antivirals, oxygen therapy, and vasodilators. And most of them do recover. We're getting an increased incidence of life-threatening fungal infections in the sinuses. So my earnest plea to everybody would be those who are quarantining at home, those who have been given steroids, if they have any symptoms related to the sinus, here again, we're back to the CT. A follow-up CT scan of the sinus is called for, especially if you're a diabetic.
Extremely interesting and important points that you've highlighted there. A lot of it, of course, also has to be what you need to watch out for post-COVID. Dr. Amarnath, would you like to shed in light before I go to the others on this, the new COVID symptoms as well as post-COVID complications that we should watch out for?
I think in terms of the symptom profile, what we saw initially was primarily the lung-related issues. But the non-lung related issues are something which we're seeing more commonly now, whether it's gastrointestinal with abdominal pain, discomfort, loose motion, nausea, vomiting, or the skin manifestations, or even neurological manifestations like headache, stroke. So these are something which we're fairly commonly seeing in the second spike. And definitely the other component is the post-COVID component. And I think one thing which we have seen very frequently, as was just mentioned, is the fungal infection. Initially starts off with the sinuses, and then we have seen certain cases where the fungal infection affects the brain as well. So I think a high degree of suspicion is required for all clinicians, especially somebody who's got ongoing COVID and people who have completed or have had COVID in the past. There has to be a high degree of suspicion to ensure that all these are evaluated correctly and treated appropriately, because certain things like the fungal infection of the sinuses, which can proceed to fungal infection of the brain, that can be fatal. So I think as clinicians, all of us need to have a very high index of suspicions, know what manifestations can happen apart from the bog standard lung manifestation, and ensure that both the diagnosis and treatment is done at the earliest.
Could that also be a cause that we're seeing that of more serious people, patients landing up in hospitals? Because Dr. Natarajan, that we in the initial days were not able to identify some of these symptoms, and that people also seem to be taking them lightly. I mean, so a common man will just take a gastric issue as a regular gastric issue, pop a pill and try to move on.
The important thing to remember is that by and large, 40 to 50% of this disease is asymptomatic. About 30 to 35% would have symptoms which would be mild. 10 to 15% would land up in a hospital. Of these, only 5% would go into the critical care. Of these, few would die, of course. That is the most important thing which the audience must keep in mind. There would be cases, yes, there are fungal infections in the sinuses, but these are very, very few and very far apart, such cases. As far as the heart is concerned, that is my specialty. What has to be emphasized and underlined is that in the past 1 year across the world, the admissions for heart attacks have declined by almost 30 to 35%. And the reason for that is the patients are diffident. The person concerned is worried, he's nervous about going into a hospital. And also, there was a paper a few weeks back in the European Heart Journal, and this is very important. What they have shown is that in European countries, the mortality because of a heart attack has increased despite the fact that these patients have been provided primary angioplasty. And the reason for that probably is the fact that patients are coming in late into the hospital. Earlier, they would rush to the hospital. Now people tend to stay back. But these are, of course, specialized territories. By and large, the disease is the same. there is no new, there are new variants, but there is no new strain. There is a distinction. There is a scientific distinction between a variant and a strain. A variant is when there are some mutations, maybe 5, maybe 10, maybe 15, maybe even 20. But the pathogenesis, the clinical picture remains the same. So as of now, even after 1 year of the pandemic, in fact, more than 1 year and 3 months of the pandemic, we only have more variants. And none of these variants have shown increased mortality. They may have shown increased infectiveness, but they have not shown increased mortality. And that is the situation in this country, because we have no increased mortality, despite the fact that you're seeing what is going on. We have all these pilgrimages, we have all these rallies, we have all these festivals.
Dr. Natarajan, as much as I would like to believe and that this is a global fact, and so it is in our country, that we are not looking at an increased mortality, I don't know, because the state governments refuse to record every case that happens as a COVID death. It just doesn't look good on their resume, and they don't want to show it. There is a massive mismatch which is happening in our country across states between what the crematoriums are telling us, what the hospitals are telling us, and what the state governments are recording, which effectively goes into the central database as well. So I would still take it with a pinch of salt. You, of course, all of you are seeing it on a daily basis, and so you have a better view. But as far as the official numbers are concerned, I would take it with a pinch of salt.
No, actually, can I come in for a couple of minutes?
Yes.
Look, I appreciate your concern. I appreciate your skepticism. But the fact is that the deaths are not that many. We all are working. We are all clinicians. We work in hospitals. Even I have a hospital. There are patients of COVID-19. There is certainly a sense that mortality has not increased. And if you read today's Telegraph, the London Telegraph, you will find that the official national statistics, that is the official stats from England, has now revealed that even their figures were inflated. 25% of their deaths were not because of COVID. So your audience must know that the distinction, the difference between a person dying because of COVID and a person who dies with COVID. There's a huge and massive difference. So you are right, maybe the numbers are underestimated, but I have a sense, I have a feeling that there is a very, very strong possibility that the numbers are overestimated. So, we have to balance.
But Dr. Pinto, how do we know that yet? Isn't it too early in the time still for a virus which is a year and a half old for us to assume that? There have been cases reported in our country where a person who's recovered from COVID has then had many other complications, including heart and lung complications and complete collapse of organs.
These are anecdotal reports. As a
so I think
different viewpoint, and as an epidemiologist, there is a different viewpoint.
Okay.
By and large, there is no increased there is no increased lethality of any variant so far.
Okay, Dr. Pinto.
So I think one of the ways to tackle this issue about reporting is to look at all-cause mortality the past year versus the current year. I believe there are a couple of studies in a couple of states which have looked at all-cause mortality, which suggests that there has been a slight increase in the all-cause mortality last year compared with the years before, suggesting that maybe COVID was responsible, because we also thought that there were fewer road traffic accidents, fewer deaths from pollution-related stuff. And despite that, if the all-cause mortality increased, maybe COVID was responsible. Of course, we can't know that for sure. The second thing about increased virulence or increased lethality caused by the virus, I think a lot of us on the ground do feel that this may be a milder version. However, if it's more transmissible and your denominator, the number of people getting infected, doubles or triples, eventually that smaller mortality is also going to cause a huge amount of load on your healthcare system. And the crematoriums, etc., that you're reporting could be a reflection of the proportion maybe being small, but the denominator, the absolute number being so large that eventually it will overwhelm the systems.
Yeah, and especially in a country with our kind of population size, the percentage obviously is different in absolute numbers. Let me come to the third and the final aspect of it, and Dr. Amarnath, maybe you can start off on that, which is on the post-COVID complications. Yes, we have an extremely high recovery rate, but are we now seeing more instances where same people are coming back with more complications?
Yes, I think on the ground, to just taken that link of what we were discussing about fatality, the CFRs, the case fatality rate is what we define. The best of centers have less than 1 or less than 1.5%. There have been certain centers which have 4%. So that's the standard case fatality rate that we've been looking at. But then that doesn't give us a picture of the post-COVID, or sometimes what we also define as the long COVID symptoms. So there have been instances where people have recovered, but post-COVID, certain symptoms, for example, we say post-viremic pyrexia, that is after the acute infection, people having fever. So post-viremic pyrexia has gone on for a few months. So that's one of the post-COVID sequelae. Yes, we've had instances of people post-COVID recovering from COVID, coming in with cardiac complications, strokes, and things like that. So it's still a very dynamic disease. It's an evolving disease. We've known it for about a year and a few months. So I think it's too early for us to say which of them who have recovered will get what type of complications. But the fact is, it's an evolving thing, and we are seeing multiple post-COVID complications and long COVID cases. Too early to put a figure on that.
No,
but
absolutely
as I said,
right. Yes,
yeah.
but if you could give us some more examples. So, for example, Dr. Badwar was telling us there are now, ear-related complications as well as, impact on your fingers and your toes that's taking place. If there are other such things that people need to watch out for, even when they've recovered from COVID.
Yeah, I think strokes are something which we need to look out for. Cardiac complications is what we need to look out for. And as we mentioned earlier on, people who have had COVID and have been treated with high dose of steroids, fungal infections is something which we need to look out for. And then gastrointestinal complications in late stages are something which we need to look out for. So these are the 4-5 top ones which we're seeing on the ground clinically for those people who have recovered last year and do still present to us in the outpatient department with these complications.
Would it be fair to say this, or is there any evidence to suggest that the COVID virus infection, Dr. Badwar, does weaken your organs more in the long term than any of the other regular virus or flus or bacterial infections that we know?
See, ma'am, there's an entity called post-viral asthenia. That is the generalized weakness which takes place after any viral infection. Your common flu and your common coughs and colds normally settle down in 2 to 3 weeks. But this is something else. This takes a toll on all individuals. And what my patients tell me, there's an immense sense of weakness and lethargy, which takes, whether you have any major complications or not, it takes a long while for you to get back to normal. But most people have had a mild infection and they do bounce back. I'm talking of a little more elderly subset with comorbidities, diabetes, hypertension, with any comorbidities related to the lungs. They take longer to get back to normal.
Okay, fair enough. Interesting point that you've made there. Dr. Natarajan, would you like to add to that?
No, nothing much, because that there is this entity called the long COVID, and a lot of information is being discussed and thrown about on this entity. I have my own opinion. I'm still waiting for this to evolve fully. I'm very skeptical about this at this juncture, at this point of time, because, being a cardiologist, I know if a person has a heart attack, then there are sequelae, there is heart failure, there are problems of arrhythmia. I have to tackle the blood pressure. I have to tackle the diabetes if it is present. I have to tackle the lipids. I have to tackle the weight. So every disease entity has sequelae. Every disease entity has a prolonged, sometimes residual effects. So therefore, with this, we have to wait and watch. It's too early. It is premature right now to label somebody as, just because somebody is weak or feels weak or has some weakness or is having lack of sleep or is being anxious, because all of us are anxious. This is in my lifetime the biggest shocker. I've never seen anything. I've seen wars. I'm old enough to have seen the 62 conflict, the 65 conflict, the 71 conflict. I wasn't around when the Second World War was taking place, but this is a huge event. So all of us are concerned. All of us are a bit anxious. All of us are on an edge. I go to the hospital every day. I'm on an edge because I don't know what's going to happen. I may contract the disease. I've been lucky for the last 1.5 years, right? So everyone is on an edge. Any sensitive person with basic intelligence will be on an edge. So there is anxiety, which could be contagious, which is in the community, which is in society. So that we have to tackle collectively. But labeling somebody as a post-COVID or a long COVID simply because that person is anxious, that I think would be stretching it too far.
No, absolutely. And in fact, it's on the actual impact on the body and the physical organs that one would need to really watch out for, apart from, of course, the other issues that it leads to. And I understand, I think in today's time, it is the medical fraternity, it is all of you who are extremely burdened and extremely stretched, and you've been at it for over a year and a half. There is so much that we still don't know about this, but we have to still try and treat people, save people's lives. And then there are those outside who don't really care, who will party, who will attend weddings, who will go on travels, who will attend political gatherings and rallies with thousands and lakhs, who will go for religious events and will fight to be at these religious events in lakhs, with absolutely no care about what it's going to do to our healthcare system. The already, under pressure, overburdened medical system that we have, and the burden that we are actually on a daily basis putting on all of you to then take care of the collateral damage because we want to be part of all of these events. So thank you so much. It was an enlightening conversation to all 5 of you for joining us this evening and shedding light on that. So yes, viewers, here are a few takeaways for you. An RT-PCR test, though still the most credible, the gold standard to detect the COVID infection, may not always be 100% correct. And so if you have symptoms, if you see a slightest hint of any of the symptoms, get to a doctor. Just because your RT-PCR test has come out negative doesn't mean that you may not have COVID. You must see a doctor. They will have several other ways, X-rays, CDs, to figure out whether this is infection. There have been cases in the city of Vadodara. Out of the 25 cases that turned out negative, 10 actually did have COVID and were in such a stage that they had to be hospitalized. This is also a reality that more and more doctors are aware of, and they know how to find out, how to investigate what infection do you have, what is wrong with you. Secondly, the symptoms are evolving as well, from body ache to joint pain to impact on your toes and fingernails that could lead to gangrene infection, to impact on your hearing and your sinus and gastric issues. All of this can also be a sign put together from these lists. So when you do see something wrong with yourself, with some of these symptoms, better to get yourself checked. We're getting far too many examples of how people are testing too late, reaching hospital too late, and then it's becoming difficult to save their lives. Act on time to save yourself or your loved one. Thank you so much for joining us.